This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract only once. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes from Extract 1. Extract 1. Questions 1 to 12. You hear a GP talking to a patient about her pregnancy. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Maria. How are you doing today?
I'm feeling pretty well. Quite tired, but, I think that is to be expected in my current condition.
Yes, of course. So you're at 24 weeks gestation, correct?
Yes, that's what I've been told, 24 weeks.
Yes, uterine size is appropriate for gestational age, and just to make sure we have your obstetric history correct, you vaginally delivered a 9-pound 8-ounce male infant 8 years ago.
Yes. Oh my, I hope this baby is a bit smaller than my son, 9 pounds 8 ounces. I had forgotten he was such a big baby.
And how is your son doing?
Oh, he's quite excited about the arrival of a new baby, though I suspect he will not be so excited once the baby finally arrives. He's in for a shock when it comes to all the crying and diapers.
Yes, I'm sure. And he is your only child, correct? You've had no other pregnancies?
Yes, only one pregnancy. I luckily have not had to deal with any miscarriages, ever.
So, let's get a bit into your family medical history. I specifically want to talk about diabetes.
I see.
Do you have any immediate family members with type 2 diabetes?
Type 2 is the kind you get as an adult, right?
Yes, that's correct. Type 2 is sometimes called adult-onset diabetes, though with childhood obesity becoming such a big problem, more and more kids and teens are also being diagnosed with type 2 diabetes. Type 2 diabetes is caused by a combination of genetic predisposition, being overweight, and a number of other factors.
Well, my husband has type 2 diabetes, and my mother too. My sister mentioned that she got tested for type 2 diabetes as well last year, but I'm not sure what became of that. She didn't say anything after, so I assume everything is all right.
Okay, so Maria, you have a first-degree relative with the condition. So, Maria, I want to talk to you about your risk for diabetes. You have gained quite a bit of weight during this pregnancy, and a urine dipstick test showed that you have glycosuria, which is an abnormally high amount of sugar in the urine. Now, your test did come up negative for ketones, which is good because it shows that you do not have uncontrolled diabetes at this time.
Okay, I think I'm following you, but just to make sure, do I have diabetes or do I not have it?
At this time, you are a likely candidate for gestational diabetes. Gestational diabetes often disappears after giving birth, but considering your risk factors for developing type 2 diabetes, it may not go away. In fact, you may have been pre-diabetic prior to becoming pregnant. But with all the tests that are done during pregnancy, it's just being detected now.
So are there further tests you need to do or just some recommendations?
Since the urine dipstick test showed significant glycosuria, it is necessary to do some additional tests to confirm the diagnosis of gestational diabetes. You may or may not have it, so let's not jump the gun yet.
And if I do have it, I'd like to know just to mentally prepare myself, I want to be self-sufficient at all times and do not really like to be a burden on anyone.
Well, in the event that your results come back positive, the most important thing we will need to discuss is how you, as the patient, can learn to keep an eye on your own blood glucose. We also then talk about dietary and insulin therapy.
I see. What about my baby? Will my baby be affected?
Well, your baby may be born a bit on the heavier side. The extra glucose in your bloodstream triggers the baby's pancreas to make extra insulin, causing it to grow large. We will need to monitor the baby closely as well. It does also mean that the baby will have a higher risk of developing obesity, and then there is the likelihood of type 2 diabetes later in life.
Oh dear.
I'm afraid there may be some complications for you as well.
Yes, you mentioned diabetes already.
Yes, future diabetes and possibly high blood pressure. But the good thing is that we caught it now and not later, so we can start working on getting it under control.
Yes, I thought I was just coming in for a routine appointment, but...
Extract 2, questions 13 to 24. You hear a GP talking to a woman about heavy menstrual bleeding. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Peters. I see you made today's appointment because you are concerned about heavy periods. Is that correct?
Yes, Doctor, I'm really struggling with how heavy my periods are. It's reached a point where I can't even leave the house for the first 2 days, and I really can't afford to be taking so much time off work.
I see. That is quite an interruption to your day-to-day life. So, what you are describing is called menorrhagia, blood loss during your menstrual cycle that is significant enough to affect your life. So, let's get a clear medical history related to this problem.
Okay, where should we start?
How old were you when you started your periods?
I think I started my period when I was about 13.
Okay, so are your cycles consistent, and how often do you get your period?
Yes, they've always been quite okay. I bleed every 29 days on the dot, and they always last about 6 days. In fact, I just finished my last period. The first was 7 days ago.
And other than your periods being heavy, do you have any other problems with them? Any pain?
No, they're not particularly painful, and I've not had any other bleeding outside of my period.
And, Mrs. Peters, I'll need to ask you a personal but related question. I hope you don't mind. But are you sexually active at this time?
Yes, I am. I have been married for a bit over 3 years, and I haven't had any other partners since I was married. I don't know if this was going to be your next question, but no, I've never been treated for an STI.
That was going to be my next question. So is there any chance you could be pregnant? Are you using contraception at the moment?
I was taking the pill, but I stopped using it about 6 months ago because we are trying for a baby.
So, a few last questions. When was your last cervical smear, and are you up to date with your smears?
My most recent cervical smear was 2.5 years ago, and they've all been normal. I've not had a letter for my next smear yet.
And in general, how would you describe your health lately? Are you more tired than usual, short of breath, changes in weight, problems sleeping?
No, I don't feel particularly tired, and My weight hasn't changed. Also a no to fevers and night sweats or problem sleeping. I would say I'm otherwise well and I haven't had to see a doctor for any other reason. Other than the pill, I'm not taking any medication at the moment.
Okay, so since your heavy menstrual bleeding is an isolated symptom and not related to pain, irregular cycles, sexual history, or intermenstrual bleeding, the most likely diagnosis is dysfunctional uterine bleeding.
And what causes that?
But your age makes fibroids less likely. I would like to do a few investigations. The first is a pregnancy test, which I'm sure you're on top of, but we need to rule it out. I would also like to check for anemia and do a transvaginal ultrasound to exclude local organic causes like fibroids, polyps, or adnexal masses.
And is there anything you can do to help me manage this problem?
Well, unfortunately, most of our management options for heavy menstrual bleeding also provide contraception, which are not appropriate in your case since you're trying to become pregnant. We do have one non-hormonal treatment we can try, tranexamic acid. It usually results in a 50% reduction in blood loss. You will need to wait until just before your next period to use it.
Okay, that sounds...
In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a doctor briefing his colleague about a patient. Now read the question.
Have you got a list of all the patients and locations?
Yeah. Who is our sickest patient?
Mr. Marcel is the sickest patient. He is a 36-year-old male with a ruptured appendix awaiting OR. He became sick over the last 48 hours with worsening abdominal pain, nausea and vomiting. We gave him fluids and brought antibiotics.
Which antibiotics and how much fluid?
Piptazo with 2 liters of normal saline so far. Imaging showed a ruptured appendix with free air under the diaphragm. I would keep a close eye on him.
Have you drawn blood cultures?
Yes. But they were drawn about an hour after antibiotics were started.
And what are the plans if there is a delay in surgery?
I haven't spoken to ICU yet, but he might need to go there if his condition worsens while he is waiting for the OR. Sound good?
Yeah, I'll speak to ICU as soon as we're done here.
Question 26. You hear part of a surgical team's briefing. Now read the question.
She currently only has intermittent late decelerations, and these have improved with her position changes and supplemental oxygen. We'll monitor her until she's fully dilated and allow her to push.
If there's any evidence of fetal distress or persistent late decelerations, we should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use them.
Great, I'll discuss this plan with Mrs. Aldrich, and we are done here. What are her vitals right now?
Normal. I just checked 15 minutes ago. She had no late decelerations since you were called.
Let's continue to monitor her. I need to know when she's complete and pushing so we can keep a close eye on her second stage.
Question 27. You hear a radiologist talking about a new initiative that has been introduced. Now read the question.
This is a big, ambitious project. We're going to focus on patient flow through the system right from the very start. When a patient sees their commission and they require support from radiology with imaging and they make a request, we want to get that request from imaging as quickly and as efficiently through the system to the reports available to the commission, so they can make the appropriate management plan and take the patient's clinical journey forwards. This is an ideal opportunity now to really embed some forward behavior, where we're learning together, we're developing together, we're looking at creating where we have today's work completed today, that there's no delay, so we're really improving the services to our patients. We are all taking control, we are all involved, and we will be proactive and not reactive, so we have analyzed CT and MRI services. We have outlined and prioritized areas for further improvement, and you can make a difference.
Question 28. You hear a pharmacist talking to a doctor regarding a patient's medication. Now read the question.
Hi, Dr. Marcy, is this a good time? I need 2 minutes to discuss about Mrs. Samuel. I'm Harper and I'm providing pharmacy coverage to the unit.
I have a few minutes. What's up?
Nursing raised a concern from rounds this morning. The situation is that Mrs. Samuel's pain isn't being well controlled. She's sedated, which is having an impact on her participation in therapies, and she's continually reporting her pain at 8 out of 10.
Okay. What's the background of the patient?
She has fallen 3 times since her admission to rehab, and she's requesting to go home at her first pass this weekend, some big family anniversary. But my assessment is that we are not adequately controlling her pain, and what we're giving her is contributing to these falls.
Okay, so what do you recommend?
Well, after reviewing her chart, I'm considering lowering her dose of opiates and introducing an anti-inflammatory which would be less sedating and she should be able to tolerate.
Yeah, that makes sense.
Her husband is coming in this Tuesday at 9 a.m. If you're available, we could meet to discuss.
Okay, sounds like a good plan. Let's meet back here and we'll talk to the family together.
Now look at question 29. You hear an optometrist talking to a patient. Now read the question.
Mrs. Wilfred, what brings you here today?
I am having trouble with my vision. I can't see and I need new contacts.
Okay, are you having trouble seeing up close or far away?
I can't see anything. I'm night blind and my eye is very itchy now. I brought my glasses with me and I want you to check them.
Okay, let me check your glasses. I will show you some lenses and just tell me if one of these lenses makes these letters look better.
These aren't working.
Okay, now I'm going to check the health of your eyes. It looks like you have a detached retina and contacts will not help in this situation. You need a surgery.
Can I get glasses instead?
No, ma'am, the problem that you are having now will not improve by using glasses.
Can you give me some drops for few months?
No, ma'am, drops will not help with your detached retina.
Question 30. You hear a podiatrist talking about a proposal to offer help with dialysis patients' foot care. Now read the question.
For the last couple of years, we were aware that a lot of the patients who underwent dialysis were at really high risk of developing complications with their feet, especially the diabetic patients. We found that a lot of them were struggling to attend our clinics and access the service. We had to come up with an ingenuity project to try and improve an element of care, and we thought this was a brilliant opportunity to look at the problem that we already identified and see if we could come up with a solution for it. So, we are offering our service to the people who would find it difficult to access our service. It would be really nice as we're making a difference to their life because they don't have to go out on their day off, and they go out 3 mornings a week, and when it's freezing cold.
That is the end of Part B. Now turn over and look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Anemia commonly complicates heart disease. Despite its association with poor outcomes and a biologically plausible argument supporting anemia correction, we found little evidence that use of ACE as erythropoietin-stimulating agents, or blood transfusions improve health outcomes in patients with heart disease. A limited evidence base consisting mainly of one trial suggests correction of iron deficiency in patients with symptomatic heart failure improves exercise tolerance and quality of life. By far, the largest number of trials has examined ACE in patients with heart failure, and most of these included patients with systolic heart failure. Though a grouped analysis of these mainly small, Single-center studies show some initial promise that a SAS may improve exercise tolerance. The evidence base is limited by inconsistent findings across trials, with some finding benefit and others finding no effect. There are a number of possible reasons for the discrepant results, including differences in patient populations, treatment dosing and formulation, and outcomes examined. For example, the largest of the trials 19 enrolled slightly older patients and achieved a slightly smaller hemoglobin improvement with DSA use than did other trials finding a benefit. However, our analyses suggest that the clearest contributor to the discrepant findings was the quality of the individual studies themselves, with the poorer quality studies generally supporting a greater benefit from a SAS and the more rigorous trials finding a neutral effect. Our review differs from a similar recent review of a SAS 72 for three main reasons. 1. We evaluated studies in both heart failure and CHD patients, though most studies focused on heart failure. 2. We conducted additional analyses investigating the impact of study quality on the overall results. And 3. We included studies of patients with advanced kidney disease if there were separately reported data for the subgroup of patients with comorbid heart disease. We felt the latter difference was justifiable because kidney disease is common among patients with heart disease, and we felt these data were important in understanding the potential benefits and harms in this population. Though there were few excess harms reported in the smaller ESA trials of heart failure patients, the excess risk associated with the SAS and CKD populations 73 and cancer populations 74 is of concern. Moreover, our own analysis suggests the potential for serious harms associated with aggressive ESA use among the large proportion of patients with heart disease and comorbid CKD. On the other hand, these data may not apply to patients with symptomatic heart failure and reduced systolic function, and they do not elucidate the role of less aggressive ESA use, leaving us with very limited evidence with which to truly evaluate the balance of benefits and harms of a SAS in patients with heart disease. While the large RED-HF trial should more definitively establish the balance of benefits and harms of ESA use in patients with heart failure, the current uncertainty of benefit and the possibility of significant harm suggest widespread use of a SAS in patients with heart disease may be premature. For patients with comorbid chronic kidney disease, the recent cautious FDA recommendations seem reasonable, as they acknowledge the uncertainty of the role of ESA use and suggest that, if they are to be used at all, patients should have HGB of at least 10 grams/dL.75. There is good evidence from one methodologically sound, large multi-center trial that intravenous iron carboxymaltose improves exercise tolerance, quality of life, and exercise duration in patients with chronic, stable systolic heart failure. 33 These results are most applicable to iron-deficient patients with NYHA Class 3 heart failure. Relatively few patients with milder degrees of heart failure were included. It also may be premature to apply these results to patients with more subtle evidence of relative iron deficiency. Biologic plausibility and test of concept studies suggest iron replacement could play a role in improving symptoms of heart failure even when, theoretically, iron stores are adequate because symptoms may be related to a functional misuse of iron rather than absolute deficiency. Nevertheless, though the criteria used to define iron deficiency were fairly broad, most patients enrolled in the FAIR-HF trial had evidence of more advanced iron deficiency and limited iron stores. Finally, though these results are encouraging and have the potential to influence treatment of heart failure, the long-term health and cost implications of this are uncertain, and harms have not been more widely assessed. Despite a paucity of data to support this contention, for decades, many physicians adhered to the 10-30 rule, transfusing patients with hemoglobin under 10 grams/dL and hemoglobin under 30% for perceived safety reasons. In recent years, recognition of immunomodulatory effects from leukocytes contamination and changes in RBCs with storage that impair oxygen exchange have led to increased scrutiny of RBC transfusion practice, culminating in the TRI-Trail. After its publication, there was widespread adoption of more restrictive transfusion standards. However, because oxygen extraction is already maximized in the coronary circulation, concern has remained that patients with coronary stenosis, who cannot increase blood flow to enhance oxygen delivery, will be more susceptible to ischemia in the setting of anemia and therefore, should generally be transfused to a higher target than the general population. Often, this continues to be a hemoglobin of 10 grams/dl. In the perioperative literature, accumulating evidence from randomized controlled trials supports use of a conservative hemoglobin trigger no higher than 8 grams/dl among heart disease patients in the intra and postoperative setting. The results of the FOCUS trial, by far the largest study to investigate transfusion use in heart disease with over 2,000 enrolled patients, have thus far been released only in abstract form, but it found no difference in mortality, ability to walk across a room unaided, falls, or readmissions with transfusion at threshold of 8 versus 10 grams/dl. While they have some methodological weaknesses, 4 randomized controlled trials in cardiac surgery, 1 additional study in hip fracture, and 1 trial in vascular surgery all were consistent in finding no difference in mortality or other health outcomes with more restrictive use of transfusion. No similar trial has been conducted in the general surgery population.
Now turn over and look at Extract 2. Extract 2, questions 37 to 42. You hear a presentation in which a researcher called Dr. Milan Petricevic is talking about the relationship between new technology and medicine in the future. You now have 90 seconds to read questions 37 to 42. Hi, I'm Dr. Milan Petricevic, and today I'd like to talk about the future of medicine. particularly in relation to the current technological revolution. To many of us, it seems inevitable that medical robots, automation, and artificial intelligence will replace many jobs in healthcare. Surgical robots are becoming increasingly more precise, and right now, man-sized robots can lift and move patients and transport them throughout a hospital. Silicon Valley investor Vinod Khosla once said technology would replace 80% of doctors because machines will be more accurate, objective, and cheaper than the average doctor. He added that eventually we won't need doctors at all. However, I disagree. Instead, I think technology in some specialties will finally allow doctors to focus on what makes them good physicians, treating patients and innovating, while automation does the repetitive part of the work. So let's look at some examples of how different areas of medicine will benefit from current technological advances. Take general practitioners as an example. Many doctors choose this specialty today because they have a chance to make a long-term impact on someone's life. And it's true that GPs enjoy tremendous trust from their patients. But seeing someone only when they are sick makes it hard to prevent disease and ensure someone's long-term well-being. It's even harder to do this when waiting rooms are overflowing and you only have 15 minutes to diagnose the illness, design a therapy, and offer health advice. In the future, wearable sensors and devices that stream data to a doctor's smartphone will notify them whenever vital signs are acting up and provide them with all the data they need wherever they are. These devices will also ensure doctors only treat patients who really need professional care, making it possible to offer simple treatment advice remotely. In turn, this will increase the time GPs have to treat and advise each patient, building trust and ensuring patients act on a doctor's advice. What's more, smart algorithms will allow GPs to tap expert advice on their patients' conditions and act as a gatekeeper, connecting patients to other specialties. And these are just a few examples. So what about radiology? Well, already IBM's medical sieve shows how artificial intelligence algorithms can scan hundreds of radiology images in seconds, doing the repetitive job of finding malignant or out-of-place phenomenon that currently radiologists have to do daily. This technology won't replace this important specialty. Instead, radiologists will have time to supervise how the algorithm is doing, or to research and innovate, making the technology behind these devices even better. Their time will be much more productive rather than spent checking hundreds of x-rays a day. Ophthalmology will bring science fiction technologies to patients in the near future. Retinal implants might give vision back to those who have lost it, or even give humans supervision, augmenting what we can already do. In sports medicine and rehabilitation, the first forms of activity records from tech like Fitbits all focused on people who exercised regularly, but only provided basic insight into how they were performing. Now, a new generation of devices tailored to professional athletes is hitting the market, with apps providing detailed insights into movement patterns and force output in any movement. Sports medicine physicians will have concrete data to measure how athletes are improving. By the time these reach the mainstream public, sophisticated algorithms will be ready to analyze data from these devices and provide personalized suggestions to improve performance and to speed up recovery. Similarly, video consoles from Xbox to Microsoft Kinect will offer a way of monitoring how a patient is doing from a distance by seeing their progress liquidly on a screen. In oncology, this specialty will pave the way for personalized medicine. Even now, oncologists customize therapies to a patient's genetic background and their tumor's molecular makeup. Cheaper genome sequencing and measuring blood biomarkers are speeding up this process, with companies like Grail working on fluid biopsies which could filter tumor cells from blood samples. Tumors could soon be diagnosed earlier and analyzed without costly surgery. What's more, artificial intelligence could soon be used to help oncologists understand and even cure cancer. Already, IBM Watson obtains all the relevant information from millions of studies about a patient's case and makes suggestions for treatment plans most likely to work. In the meantime, patients are better informed about the disease thanks to social media communities of fellow patients. These signs all point to a bright future for oncology in partnership with new tech innovations. So what does this all point to? Well, my conclusion would be that, all in all, many jobs will be taken over by robots and automation in the coming years, but at the same time, amazing opportunities will also emerge, especially in medicine. These will require physicians to acquire new skills and improve their existing ones. In my opinion, the majority of specialties will have more time for patients and better insight into disease. That is the end of Part C.